question, and I really appreciate that. Following the issue raised by Dr. Haki, you know, physicians are very poor in trying to advertise what we know and what we could do, right? So what we really intend to do is to bring this up to our politicians, because we wanted this to be, there should be a legislation for this matter. And the only way which we feel will be more effective is through you, through the media. For instance, after this talk that we have gone through, probably you can bring out the problems to them, the national problem, the burden that we're seeing, because they have to be aware of this, so that they will be able to come up with some kind of legislation in order to improve the outcome of cases with stroke in our country. Just reducing the incidence, reducing the prevalence, reducing death rate will be very, very significant.
Maybe I can add a few words. In Austria and also in Germany, the healthcare situation is different. Firstly, we spend much more money per capita on healthcare. It's probably 20 times to 30 times more than in this country, number one. Number two, we do not have privileged services for private patients. Our healthcare is expensive, but it is available for everybody. And the cost is either covered by health insurances, which are legally required, or by governmental institutions for those few people who don't have it. And for example, for our visitors, people that come from abroad and get the health care. And as you heard from Professor Breinin, in 1997, they founded the first stroke unit in his hospital. So that's a story of 20 years now. It's about the same in Germany. And here we must say it was essential that, at least in my country, that the politicians recognize how important stroke is. So they asked the neurologists to come up with a concept, which was then taken by the state administration and made happen. And it's paid for by the states, and the running costs are paid for by the fees that the insurances pay for the patients that are treated. That's a big difference, and as long as there is still this private patients get best care, and because they can pay out of pocket and the others don't have access, it's difficult. But it's very important. The government will be forced to take a stand, because the WHO has just decided to make this drug that opens up vessels again an essential drug by the WHO. And being on the list of essential drugs means that every country has to report to the UN and the WHO how they are planning to make the essential drug available and affordable. And they have to report. Whether the report is a success or whether the report we could not do anything about it. But politicians don't like to report failure to the WHO. That's a big chance.
Can I just ask some questions, guys? Because I'm all for this AGIL's initiative, because I do have a mom who is a stroke patient. So I would just like to know from Mr. Fisher, could you give us a little perspective on the current needs of hospitals to be like stroke ready?
As I mentioned before, patient the patient, for the patient it's a lottery to come into the right hospital. So we normally say a patient has to come, must have the option to arrive at the hospital, stroke ready hospital, in 45 minutes. So you can just make a circle around the hospital and you see how the country is covered. And so if you're outside the circle, the chance that you are treated with a positive prognosis is very small. But on the other side, as Professor Hacke said, patient can be treated. And this we have to communicate to the politicians. Stroke can be treated. And so it's not a fate for the patient to get the stroke and not to be treated and to be disabled for the rest of his life. They can be treated, and this is not only you can not only prevent the disaster for the patient, for the whole family. You can also prevent the high burden for the society, because a disabled patient costs also a lot of money. I don't want to of course, to be disabled, that's horrible enough, but it costs also for the society. So politicians should be interested, and we see more and more countries who see this. Egypt, for example, they also decided to build up 46 new stroke-ready hospitals because they see it's important. And also here, the journalists were really crucial to communicate it to the ministry.
All right, some more questions, please. Yes, David?
For Sir Thomas, I would just like to ask about, there are currently 11 stroke-ready hospitals in the Philippines. Is there a target for you, how many hospitals you're targeting to make stroke-ready, and what are the requirements for a hospital to be stroke-ready?
So I think Professor Brainin already said that from the current calculation you need around about 360 stroke units, which seems to be very high. But so we can do it stepwise. If you have now 30 hospitals round about stroke-ready hospitals, so it doesn't matter if you want to be at 360 or so every stroke unit they can add is a win. So let's go for the next 100, that we have let's say a realistic goal, and then to find out how this can be improved. For stroke-ready hospital, you don't need so much as politicians always think. You need a CT, you need, which is most important and which is a bottleneck in a lot of countries, but also specifically here in Philippines, you need neurologists who can treat stroke. So education of young doctors is important and crucial, including also stroke nurses, and access to the treatments for thrombolysis, thrombectomy in the best case. But you can also do quite a lot just doing basic nursing care. Just doing this dysphagia screening, so patients have problems with swallowing, they get lung infections due to aspiration, and this costs a lot, this makes people ill, they die or are disabled because this, not of the stroke, but of the secondary infection. So you can also do a lot of stuff on a broad level without having always access to the newest drugs or treatments. Of course, we should have this as a goal in mind, but you can start everywhere.
Just a moment, Dr. Navarro, would you like to add anything?
Yeah. This is what we're doing right now in the Stroke Society in the Philippines. We're trying to accredit stroke-ready hospitals in the Philippines. So what are the requirements that we would ask from this hospital to be granted a stroke-ready hospital? Number one, they have to have a CT scan. This is very crucial in the diagnosis of stroke. Secondly, that they have the capacity or capability to administer thrombolysis, the RTPA, or the recombinant tissue plasminogen activator. And thirdly, they have to have a neurologist, and if they're not present, they have access for a neurological consult, either by telemedicine or whatever media that they could use or utilize in order to get neurologic consult. So these are the three things that we would require from each hospital to be declared as a stroke-ready hospital. Okay?
Thank you, Dr. Navarro. Any more questions? Yes, Sir Janine?
Dr. Navarro, just a follow-up. You mentioned earlier there are only 400 plus neurologists or stroke specialists in the country. Is this a problem of awareness or interest in terms of our medical students, or is our medical schools in the country not equipped enough to offer neurology as a specialization?
Well, goes like this. Neurology is a very hard subject. Okay? It takes brain to know the brain.
Okay. We all know that.
So it's very difficult to entice medical students to go to neurology.
Yeah.
It doesn't mean that no students go for training in neurology. We have 7 training institutions, and we do graduate almost about, I would say, 10 to 15 neurologists every year from these different institutions. Now, the problem is not the number of graduate neurologists, but rather the distribution, because they stay in the city. So there's a maldistribution of neurologists. 90% stays in the city. So the 10%, they're just distributed all over the Philippines. So can you just imagine, so how would they be able to handle stroke patients? Now, aside from that we're talking about the 400 of the neurologists, that there are certain people or certain neurologists who are really very interested in stroke, and they've devoted their life and training, further training on stroke. And there are only few of us who are doing that. And these people are really interested in stroke. Mostly are going into administration, putting up things like a stroke unit, stroke-ready hospital. So the management really goes into our neurology residents.
So if it is a problem of economics, just a vague, just give us a ballpark figure. How does, if a Filipino, a normal Filipino is going to suffer from a stroke now, how much in a ballpark figure will that patient have to spend?
Ballpark figure.
Yeah.
But that depends on.
Considering that you mentioned earlier that 38,000 comes from the PhilHealth, right?
Yeah.
Okay. Considering that the person has PhilHealth and that it is and he is allowed to be given 28 to 38,000. I mean, how much more does one person have to spend?
Okay. On the average, patients who develop stroke without any complications, they may stay in the hospital for about 5 to 7 days. We're talking about mild to moderate, not the severe. The severe stroke, they stay for a long period of time in the hospital. But those with mild and moderate strokes, probably they just stay for 1 week or less, just for workup, looking for what risk factors, what could have caused this stroke. So they just stay in the hospital. For that alone, for all these tests, probably they will be spending around 50,000 to 80,000 pesos. Of course, depending on the hospital. If you go to Global, that will be more. Right? If you go to my center, Sarasima Hospital, no bill value. Don't pay anything.
So, Mr. Fisher, continuing on that question on that line, will the prices change if a hospital is accredited by Angels, or if one particular professional is a registered specialist of Angels? Does it change for us? I mean, considering we have a Filipino would have to pay $1,000 in equivalent. Will it change if it will be coming from an Angel specialist?
No, we have no influence on the price, so we care for building up infrastructure. However, we have also to see, the cost of the medication. I don't want to play it down, so I think there are a lot of reasons to decrease the cost for medication which are essential in countries, but in a lot of countries. But on the other side, the price is not only dictated by the companies, but also by taxes, by pharmacy fees, and so we have to look very carefully into this if you want to tackle this. It's not the task of the Angels. We want to build up infrastructure, and If you just to say, if you give one drug now, in this day, Alteplase, it's one shot for the patient. Its costs are quite impressive if you look at the price. But if you think about prophylaxis, you need prophylaxis for years and years, and so the cost effectiveness is also very much important. But on the other side, again, I think we have to show the politics, the politicians, and the stakeholder, the decision makers in the countries, that to treat stroke is very beneficial for the patients, for the relatives, for all the caregivers, but it also reduces the money you have to spend for the patient to keep them in a relatively low quality of life for the rest of his life. And I think to spend the money for treatment and prophylaxis is, I think, the best invested money you can spend.
Thank you.
All right. I would just like to ask Dr. Michael Brainin of the WHO Mission Vision. Sir, can you share with us this afternoon the mission vision of the World Stroke Organization to further for the further stroke education worldwide?
Well, this relates to what's just being discussed. How do we get people, health personnel, also doctors, ready to tackle the emergency situation of stroke? And only when we understand how this emergency develops and what can be done, then we can alter the structures. I'll give you one example. Usually the CT is far away from everything else. It's in the radiology department, and in the emergency department there are a lot of trolleys and trays and things lying around. So if somebody comes to the emergency department, we quickly have to get him into the CT once the suspicion is raised that this could be a stroke. Because without the CT we cannot confirm the diagnosis. So understanding this, the doctors responsible go to the hospital administration and the healthcare planner and say, we need the CT very close by so we can reduce the investigation time, or to get priority scanning, and if somebody has something less urgent, he must wait because the emergency goes first. So this kind of training is provided, of course, with the Angels program and other programs. So that's why I said the stroke-ready physician. In prevention as well as in the acute treatment, it is important not only to deliver a drug, like let's say in cancer, you need the cancer drugs and the patient has to take the cancer drug. At the same time, and this is the special thing about stroke, is you also have to deliver the care. So the drug alone doesn't cure, the care alone makes only half the story, but everything together is the ideal situation. So for this we have online learning platforms and special CME programs that you can finish. And the ideal situation is the drug plus care. Also neurorehabilitation also has drugs. So drugs plus care is ideal. Does that answer your question?
Thank you so much. Is there any more questions from the floor?